Hi, I'm Howard Lux.
And I'm Jeff Berg.
The two boneheads are back again. We have 40 years of orthopedic surgery experience between the two of us, and we're going to be talking to you about various topics on a weekly basis. This topic today is about PRP, or platelet-rich plasma. What is that, Jeff?
Yeah, so plasma really is blood, as you know, Howard. And in blood, there's really three cell types: white cells, red cells, and platelets. And the platelets are typically thought of as being clotting, having primarily clotting factors and helping in the clotting process. But what we know is, and as you know, there's growth factors in the platelets. And these growth factors are activated and amplified when there's injuries. And so the thought is that if we could do that, if we could somehow concentrate these growth factors and then get them to work, we could put them in certain places and get things to heal or make things heal quicker.
Right. And that's what patients are reading. They know that people, such as professional athletes, are flying overseas to get these PRP injections. We'll save stem cells for another day. And people envision that this is going to cure everything, and everyone is asking for it in the office. I know you're thinking about it out there right now. Surgeons and other doctors are injecting it everywhere for everything. But it's not what you think. It's not the cure-all for everything. It's only working, as proven by research, on a few basic issues or conditions. We're going to review those today. How do you prepare the PRP, Jeff?
Yeah, so there's a couple systems out there, and but basically they're all very similar. What you do is you get blood from the patient, and different symptoms, different amount, but it's just like any other blood draw. And then usually we just spin it down, and there's these sterile kits that you spin it down, and you get this sort of goop, and then you put it in a syringe, and it's real simple. You just inject it into the area that you're worried about. And sometimes you can use ultrasound to isolate where that area is. A lot of times you can just use the point of tenderness. But, as you alluded to, the problem really is I think there's probably some promise here. And probably over time there will be something here. But right now I think we really are being a little simplistic in how we think about it. We're taking the goop and we're injecting it back. But I think the cells need a little more from us. They need to be activated. They need to be stimulated. And I think that's why it's really not working for most things.
I agree. What Jeff is alluding to is there are so many manufacturers, and each kit has a different amount of blood. The centrifuge spins at a different amount. Some collect white blood cells also, some don't. Some activate the cells by injecting something, others don't. It truly is the Wild West. We're not comparing apples to apples in the research projects. One surgeon is doing one thing, another surgeon is doing another thing. One is using ultrasound, one isn't using ultrasound. One lets their patients take anti-inflammatories, which kills the PRP, and others don't. So it's really hard to digest the research. We pretty much agree. We use it for two main reasons. One is called tendinosis. That is the reason why those of you with tennis elbow have such severe pain on the outer side of your elbow, and why you basketball players get patella tendonitis, or what we call a jumper's knee. Are there other conditions that you use it for, Jeff?
Yeah, well, I think out there what you will find is that there's really four reasons people are using PRP. They're using it for muscle sprains and strains, try to get them healed quicker and get people in the field quicker. Tendinosis, like you talked about, Howard. Arthritis, and we'll talk about that. And then in the operative, in surgery, to try to get your ACL or your rotator cuff tear to heal better. I think that it's pretty clear at this point with the way we're doing PRP that it's not working in the surgical field. It's not, or in the surgical area. It's not working when you give it around rotator cuff repairs or in ACLs. We're not seeing any real great improvement there. Muscle strains and sprains, the data is not great. There may be a little improvement, but I think overall we're not seeing great benefit there. And what we're really seeing, at least now, the data that I see, is in some forms of tendinosis, like you talked about, lateral epicondylitis or medial epicondylitis, tennis elbow is a big one. And also there's some recent data out there for arthritis that it might be beneficial in knee arthritis. So they're the two main places that I use it. You talked about patellar tendonitis. I think that's a good one for the reason that it may or may not work, but we know that surgery is usually pretty poor for that. And I think as a last-ditch effort, I'll sometimes try that. Sometimes try PRP for patellar tendonitis too.
I agree. And there is some research to support use of it around the elbow. Some research is starting to appear for its use around the knee. The research is very clear. It does not work for Achilles problems. If you have Achilles tendonitis, Achilles tendinosis, and someone's injecting PRP into you, unfortunately, the research shows it's probably not going to work. The arthritis literature is interesting, though. HSS has published some studies showing that they believe that the progression or worsening of the arthritis is diminishing. It's also, the PRP seems to function as a strong anti-inflammatory. Bottom line is we're not really sure. We do know that these two areas specifically, the tendinosis and the arthritis, it's probably worth your time and unfortunately worth your expense. But around surgery and to expand its use for other reasons, right now, we simply can't suggest it.
Yeah.
What about the cost?
Well, that's the problem. So I was going to bring that up. You talked about your expense. I mean, the big problem here is it's not really paid for by insurance. So when you tell somebody, well, it's got a small chance of maybe making you better, and they're coming out of pocket for it, that sometimes is hard to get them to want to do it. And I think, it can be expensive. I mean, like you talked about the Wild West of what people are doing, the charges are wild, Wild West. And it can be awfully expensive in some places. And so, I think if a patient really wants to do it, it's typically coming out of their pocket. There's not a lot of harm with it. And I think, there are some areas, Achilles tendonitis, like you talked about, that really isn't a lot of good data to show it. But I think some patients still would rather give it a try than surgery. And I think that's an economic decision they have to make based on the cost.
I agree. And I agree with what Jeff said when we started. It looks like we're onto something, with PRPs and stem cells. And in the future, it's likely going to have a much, much larger role than it has now in the treatment of various maladies or issues with your extremities. But that day is not right now. Spending tens of thousands of dollars or $5,000 or any amount of money on uncertain uses is probably a waste of that money. So,
yeah, I think like most, it's not uncommon for things to develop in the fashion that this may be developing. It comes out with a big splash.
Right.
Everybody does it. You realize that it's really not working the way we're doing it. And then it starts to be changed.
Right.
Or it goes away. So right now people are starting to add in stem cells. Like you said, we could talk about that another time because they realize that the PRP by itself isn't doing the job. And there may be something to the stem cells to activate it or increase cell counts. But like you're saying, I think we're on to something. We're just not quite ready to go full force with it yet. I don't think we really know what we're doing.
I agree completely. So we hope we helped increase your education about PRP and what it can do and what it will not do. And stay tuned for future talks. Bye.
Bye.